So, welcome to next installment for the GAP MASLD MASH Community Network. I'm so happy today to be speaking to you guys about fatty liver disease and how we diagnose it. And today we're going to be talking specifically, if I can get everything moving. Maybe. Why is this not? I hope it doesn't do that the whole way. Okay. Talking about comparing F3 and F4 fibrosis. I will say that this is a topic that is extremely precious to me. It's something that I've been very passionate about since I got into liver disease, because I think this is the hardest thing that we are tasked to do, is trying to figure out when somebody gets from bridging fibrosis or from evidence of early bridging fibrosis to cirrhosis. And all it is, we're talking about a trajectory of disease. We're talking about, when we talk about the amount of damage in a liver, which is scar tissue, we're talking about how closely are nodules forming. So do we have kind of like wispy tendrils of fibrotic tissue just barely touching, or are we talking about a solid nodule and nodular appearance? Because we know that there's significant health risks associated with cirrhosis and different treatment decisions. So this is a very difficult thing to diagnose and to determine.
Hey, Janet,
yes.
I'm so sorry. Oh, I don't know if it was just me, but you went like really quiet there. I'm so sorry to cut you. I'm so sorry to cut you off. I don't know if you can like start from the beginning, maybe. I don't want to like.
Happy to start from the beginning.
Yeah, maybe.
I apologize for everybody that's what the issue is.
Yeah, I don't know. You're fine now, but maybe it was just me. But
hear her the whole time. This is Lindsay. So
okay,
for what
you
that's
could hear
worth.
her the whole time. Okay, well,
Yeah,
if it happens again, I'll just let you keep going. But yeah, sorry about that.
Well, you know what I don't like though is that I can't.
Yeah,
Okay.
it wasn't going. Yeah, it's looking a little bit weird to me right now.
Just maybe give it a minute to simmer out. And
Yeah.
Lindsay, was my connection going in and out at all?
no, not for me. Everything looked fine.
All right. I just wanted to make sure that, again, I kicked my kids out of the room and I'm trying to making sure that nobody's streaming or anything. So, anyways, all right. You know what? Hey, this is life. This is digital era. We get issues like this. I'm happy to be here. I'm happy to talk. And you know what? May I set the bar in a way that everybody else can do fantastically.
Could you just try unsharing and resharing again though? It's just there's like these little boxes that are showing up on your screen share. Just so strange. Maybe if you just reshare it again, but never seen that before.
Share. Okay, I just want to say, you know what? How about if I am wondering if I'm just going to try just sharing my screen instead of sharing a particular box. Oh, you know what? Hold on. Hold on. Whoa. Let me just do something here. Whoa. Let's do this. Let's do this.
You know, I'm taking notes so that I can work through these things too. So thanks.
Michelle, this is my second presentation, and I will say that the first one went better. This is my laptop, so I'm wondering.
The screen looks great now, though.
Okay.
I think you're perfect now.
Michelle, since you said you're taking notes, what I can tell you is that I unchecked optimize for video sharing. I don't know. All right.
Perfect. Thanks.
Welcome to the next installment of the GAP MASLD MASH Community Network. My name is Janet Gripshover. I'm a nurse practitioner and nurse manager of the Liver Transplant Program at Cedars-Sinai in Los Angeles. And I'm so excited to be here to talk to you guys today about, there we go, comparing F3 and F4 fibrosis and why I think this is so important. This is something that I have harped on for probably the past umpteen years that I've been in liver disease and liver transplant, because this is, I think, the crux of what we do in hepatology. And I think this is one of the hardest things that we are tasked with, because what we're trying to do is we're trying to figure out where on the continuum of liver damage, which is increasing fibrosis within the liver, where somebody is and how close they are to getting to the top of that scale being cirrhosis. So you have stage, fibrosis stage 1, 2, 3, and then F4 and cirrhosis are the same thing. So again, how close are you getting to cirrhosis? And why it matters is because once somebody hits cirrhosis, management changes, risk for other diseases changes, risk for decompensation changes. And so it's really important that we can really accurately, as best we can with the tools that we have, which none of them are perfect, and we're going to talk about that a little bit, to identify who is at risk and who needs that extra attention and who needs intervention so that they don't get to that next stage. So again, I'm so glad that you guys are joining me, and here's my name, how to spell it. It doesn't always match how it sounds, and let's dive in. Oh, before we do that, make sure that you register for this meeting. Make sure that you get credit for this meeting. Again, I always like to document what you do. It's always a good idea to, and you may be able to count it towards education. And if you have any questions, if I've inspired you to learn more about MASLD and MASH, previously known as fatty liver disease, you can visit the MASLD Community Network, and you can view the Madrigal Mass Disease State Education and Madrigal Resdifra Promotional Program too, to learn more about treatment options for MASLD and MASH. All right. And with that, let's go ahead and dive into our first case, which is case 6 with Sam. Sam is a 55-year-old male. He's been referred for mildly abnormal transaminase levels and an abdominal sonogram, so an abdominal ultrasound with increased liver echogenicity. So basically what that means is that he's had an ultrasound that shows that the texture of the liver isn't very smooth. It's got differences in the way that the sound waves from the ultrasound bounce back at the liver. And he's complaining about being tired, so you can tell him to join the club on that. And you can see a little bit of his demographics there on the side. Things that kind of stand out to me a little bit is that he's got a BMI of around 33, so he's a little bit on the heftier side. And so already we know that he's got a cardiometabolic risk factor for having fatty liver disease. And guess what? No surprises here in his medical history. He's got diabetes type 2. So we've got now 2 risk factors for cardiometabolic risk factors. He's got high blood pressure. He's got high cholesterol, sleep apnea. No surprise that the BMI is 35. And very important in your diagnosis is no history of alcohol use. And the reason why is because, I'll give you a little history lesson here, is that way back a long time ago, back in the 80s, and probably even before that, we thought that anybody who had fat in their liver were just alcoholics. They drank all the time. And even if they told you that they didn't drink at all, that they were just lying. They were hiding it. And it wasn't until there was actually a study done of a group of individuals that had no access to alcohol, had no reason to drink. I believe it was a convent that they studied this in. And they found that people who had cardiometabolic risk factors and no history of alcohol use would still get fat in the liver. And that's when they developed this non-alcohol related fatty liver disease, which we now call metabolic associated fatty liver disease. And really the main difference between these 2 disease states, alcohol related liver disease and metabolic associated fatty liver disease, is history of drinking. Okay. And so the fact that this guy has no history of any alcohol use, and he's got cardiometabolic risk factors, dramatically increases his risk of having metabolic associated fatty liver disease. So let's take a look at him. So we know on physical exam that he's a little bit overweight. He's got no advanced liver disease. And when you see him, or no sigmoid advanced liver disease, really what that means is that he doesn't have any palmar erythema. So his hands, we don't see any red hands in there, and we don't see any spider angiomas, which we would typically see on his neck and possibly upper back. And those are signs of having cirrhosis. Okay. When you see that, you should have your little spidey senses going off, that you can say spider angioma, spidey sense, that there might be some advanced liver disease going on, and you should be suspicious of having cirrhosis. Medications, again, nothing, no surprises there. He's got a blood pressure medicine, he's got cholesterol medicines, and a diabetes medicine. All right, so here we go for labs. What we can see on his labs is that his blood pressure is a little bit up. Again, not surprising. Again, another thing, we know his BMI, he's a little bit on the heavier side. His transaminases are elevated. We typically talk about elevations in transaminases to be around multiples of the upper limit of normal. And as a rule of thumb, I have always kind of considered the upper limit of normal around 40. Again, it's just a quick and dirty, so I can do math quickly in my head. So he's approximately 1 to 2 times the upper limit of normal for his transaminases. His alkaline phosphatase is on, I would say, on the plus side of normal. Nothing necessarily to sneeze at, but what I would typically take away from this alkaline phosphatase, though, is that it's pretty at least close enough to normal range. Again, my knee jerk for alk phos is somewhere around 130. And when we talk about multiples, and we can see that his AST and ALT are elevated much more than his alkaline phosphatase. So this tells me that whatever's going on in his liver, it's a hepatocellular issue, not a cholestatic issue, because typically if it's a cholestasis, you're going to see that alkaline phosphatase being much more elevated in relation to your transaminases. We can see that his total bilirubin is around 1.17, which again is within normal limits, maybe on the plus side of that, but nothing to be too worried about there. His platelets at 157, within normal limits. His hemoglobin A1C at 7.1. Again, not surprising knowing with the medicines and his past medical history. We can see his creatinine and INR are all within normal limits. His ferritin is within normal limits for a guy. And again, we would be more suspicious of something being a little bit more risky there. Again, if that was over 1,000, that's kind of like my little, off the cuff assessment for that. I'm sorry, ferritin saturation or iron saturation around 30% within normal limits. His ANA at 1 to 80 is not diagnostic, but does raise a question mark. Could this be an autoimmune process? Now, one of the things that you might want to look at is that autoimmune diseases travel in packs. So, you might want to take a look and see, like, are there any other autoimmune diseases that he have on board? Or could this be just a false positive and a red herring to make you look down that track? But we have here his smooth muscle antibody and his viral serologies are all negative. So again, with this kind of profile, we know he's got cardiometabolic risk factors. He doesn't drink. There's no sign of any iron overload. His ANA, again, maybe a little bit questionable. But so the things that I'm thinking about right now is this fatty liver disease? Is this, does he might have a little bit of a touch of autoimmune disease? Although, again, that's a little bit less likely. My finger is really at this point pointing towards fatty liver. All right, so one of the cool things that we can do with these labs is that we can check a FIB-4. So we do that on our patient and we come up with a 3.1. Now, what you can see here is we put these little cheat sheets up here for you because they're hard to sometimes remember. And when you calculate it out, you might have to compare it. But generally speaking, just to remind you about a FIB-4 is that it's a really great, what I call a quick and dirty, because you can do it with just the labs, basically all the information that we already have. You can go ahead and calculate and see if that 3.1 is still correct. But what we know with a FIB-4 is that if that number comes back less than 1.45, the likelihood of there being advanced fibrosis is extremely low, basically negligible. You can basically assume that there's no advanced fibrosis there. If their FIB-4 comes back at greater than 3.25, the likelihood of advanced fibrosis, so basically F3 plus, is extremely high, and it's likely that there's cirrhosis there. So we have this guy, we calculate him out to a 3.1, so he's coming up at this indeterminate risk, or intermediate risk rather, where we don't really know if there is advanced fibrosis there. So we go ahead and we send him up for a FibroScan. which remember, you might want to remember that he's a little bit of a bigger gentleman, so he might be a little bit difficult to get an accurate reading on. So it's just something to keep in mind. I can't tell you that it's going to be higher or lower than usual, but we get it back anyways, and it comes back showing at 11 kilopascals, which, you know, it's interesting because it's kind of coming up consistent with what we're seeing on the Fib4, is that it wasn't quite above 3.25. The FibroScan, again, as a rule of thumb, the higher your FibroScan is, the more likely that you have cirrhosis. A cutoff of 12.5 has been suggested as a good cutoff for having cirrhosis. So again, it looks like he's on his way, and whatever's going on in his liver is something that we definitely need to address, because it looks like so far we've got 2 different tests of 2 different modalities that are showing that his liver is headed towards cirrhosis. So we really do need to figure out what's going on. FibroScans, oftentimes when you do them, they'll come up with a CAP score. This is a score that gives you an assessment of how much fat that there might be in the liver. Again, it's not exact. It's not something that you can really, it's like a blood pressure. It's kind of, you have to kind of take it in stride with everything else. But his CAP score is also elevated. So, remember how I said on the last slide, when we're looking at this profile of labs, we know he doesn't have viral disease. We know he doesn't drink. So he's got cardiometabolic risk factors, and now he's got this elevated CAP score. So right now, as I said before, my suspicion for fatty liver was high. It's gotten even higher because of this elevated CAP score. That ANA 1 to 80 is not considered diagnostic in and of itself. And again, he doesn't have any known history of any other autoimmune diseases. So my suspicion for him actually having some autoimmune component to this is now even lower. And then we can also get an ELF blood test. Again, it's a proprietary blood test for those who have been in business for a long time. It's a lot like the old FibroScores that we used to get. And we can see that, again, it's also consistent with the same level of this F3 headed towards cirrhosis, but nothing's really clicking us over into cirrhosis. So that being said, I know there's a few people that have tuned in here, and you can feel free to throw it in the chat. Is there anything else that you guys would want to do to assess what's going on with this gentleman? Or do you feel fairly comfortable in saying that you think that he might be an F3? I'm just kind of curious what people might say.
I think you have pretty concordant results here. I mean, I'd feel pretty confident that he is an F3, honestly, from what I see.
Yeah, thank you so much. I feel the same way. I feel pretty confident. Everything's concordant. And what I love about these results is that these results is that we have different modalities saying the same thing. So it's not just like 2 blood tests. I would be a little bit more suspicious if it was maybe the ELF blood test and the Fib4 showing an F3 and then my FibroScan showing an F4. I was like, well, okay, so I would maybe, again, like more suspicious on that, because the FibroScan is a completely different modality. It's not using some of the same measures that blood tests would. So again, I put more credence into different modalities of testing when I'm trying to get a sense of how much damage is there. I think we can all agree on, though, that this guy's in trouble and we need to do something, because he is towing the edge of going over that cirrhotic line. All right. Oh, we already talked about that one. Any further testing that you would like to do on this guy? Or do you feel pretty confident that you know what you're seeing? No further testing? Anybody want to get a biopsy to see if there's like really autoimmune disease going on or anything like that?
I don't think you need a biopsy. I think the history, your labs, your non-invasive testing is consistent with MASH and with stage 3. I mean, I'll sometimes offer or have patients that want a biopsy to confirm, and that's certainly not wrong to do, but I don't think you need to in this case.
You know what? I completely agree with you. And honestly, if you had even come out and said, I think that we should get a biopsy just to rule it out, I also would have agreed with you. It's whether you do it or not. I think I love the fact that you said, hey, I would leave it up to the patient. Biopsies aren't fun. They do have some risk to them. So it's not unreasonable to say, hey, I think, I think that there's a possibility of this diagnosis here. Do I think this is driving all of this? No, I don't think it's really driving of it, but it might not be a bad idea to find out. So again, I don't think there's any wrong answers to biopsy, yes or no. And I love involving the patient in making these decisions, because heaven forbid, you say, no, this is definitely fatty liver. We're not going to need a biopsy. And really the patient thinking, I really wanted a biopsy just to see, because you want to have shared decision making. All right. And then how would you stage this patient? I think that we already discussed that we would all call this guy an F3. So that being said, what would you consider doing for this patient, and how would you want to monitor this patient moving forward? So some of the treatments that are out there, I'm so happy to talk about a new treatment that we have with resmetirom, which can help decrease the amount of fat and also halt progression of the fibrosis into cirrhosis. So it can kind of help stop that. He does qualify for it, having an F2 to 3 fibrosis. We also certainly want to talk about lifestyle modifications. So we know that people, when we tell them to lose weight, they lose maybe about 5% of their body mass, that we can help move fat out of the liver. And if we can drive it all the way down to 10% weight loss, we can actually reverse fibrosis, again, to an extent. That can be very hard. Again, when we're talking about, I think we said he was 235 pounds. So I'd probably eyeball and say, let's start with approximately a 12-pound weight loss, which sounds tangible. And then if you want to say like, well, really, we're trying to get you back from cirrhosis, we want to get you to a 25-pound weight loss, that might feel a lot more daunting. You may want to consider starting a GLP-1. We know that these medicines can also help reduce fat out of the liver. And again, the mechanism thought behind it is because it helps patients lose weight. So you're getting a little bit of a twofer on that. And it's really a threefer, because we know this guy has diabetes. So maybe it'll help get his A1C a little bit under better control. And we might want to consider monitoring for hepatocellular carcinoma. And the reason I'm bringing that up is because we don't know when people really change their risk from going into cirrhosis. We don't really know that. Again, we can say that he's likely an F3. All the signs right now are pointing to an F3, but at some point he's going to have his risk for hepatocellular carcinoma really go up. There's also some evidence out there that those who have fatty liver disease with an F3 are at an increased risk for liver cancer. And the thing about liver cancer is that if we find it early, we can cure it. If we find it too late, we may not be able to do anything about it. And that's a death sentence right there. So somebody who works as somebody who works in transplant, you always want to find that liver cancer early, because the more earlier you find it, the more treatment options there are available for you. All right. So let's take our same gentleman, Sam, and let's add some tweaks to his case. So we're going to start with the same guy. Remember, he's 55. He's male, BMI of 33, same past medical history, same physical exam, same meds. But we got his vitals. Vitals are all the same. Again, weight 235. Blood pressure is a little bit on the plus side. His transaminases are 1.2 times the upper limit of normal. Alk phos is around normal on the plus side, but we see that his billy is a little bit up. His platelets are a little bit down. And his creatinine's a little bit on the plus side. And why I really want to highlight these three changes is because total bilirubin of a 1.4, to me as a liver person, that means nothing. You can get that. It's not normal by any means, but you can get that from lots of normal issues like Gilbert's syndrome, which is basically a genetic, I don't want to call it a disease because it's not even a disease. It's basically a genetic quirk where your body doesn't recycle bilirubin like it should. And so you can get mild elevations in your total bilirubin. A 1.4 isn't really anything to sneeze at, but it's one of these things to click, okay, well, why is his bilirubin up? Something's wacky with that. More importantly, the most important abnormal thing that I see here is that platelet count of 128. That is not normal. And that significantly raises my suspicion of advanced fibrosis being on board. The reason why platelets are important is because when blood can't get through the liver very well, it backs up. And the first place it backs up to is the spleen. And when that happens, the spleen gets bigger. And when the spleen gets bigger, it holds on to certain cell lines in your blood more than others. And the very first one that it holds on to is the platelets. So you'll start to see the platelets going down. Now, never worry, your body can still clot. It can still do everything it can with a platelet level of 128, but it makes me worried. Oh my gosh, is this process starting to happen? And as a little pearl for you guys to keep in mind is that when you have a platelet count of less than 100 and evidence of liver disease, that's nearly pathognomic for this issue happening. So, that platelet count of 128 is not going the right direction for him and makes me very nervous. I like to highlight also the creatinine going up a little bit. That suggests to me that maybe, well, his kidneys are not happy, right? So why aren't his kidneys happy? Is it because his diabetes isn't under control? Maybe because his blood pressure's been a problem. Maybe his liver, one of the things that happens is that when your liver doesn't work very well, all of your other organs try to pick up the slack. And maybe his kidneys are getting stressed out because the liver isn't doing their job. Now, okay, if there's liver people on listening to this, that's not exactly how that goes. I get it, but it's a good way to kind of remember that your kidneys can get affected and they can get really sensitive in chronic liver disease. Everything else is the same. All right, same patient, but different scores here. Non-invasive testing scores. So we see that his FIB score now calculates to a 3.36. We see his FibroScan is a 21. Both of these scores are consistent with having cirrhosis. And there's also some data out there that shows that a FibroScan greater than 20 kilopascals is consistent with having portal hypertension. And that's that process where blood can't get through the liver very well. And so it backs up and in that portal vein can get high pressure situation. And again, that's consistent with what we see with the platelet count. His CAP score is actually a little bit on the lower side. And I think that that's a little bit of an interesting finding. We sometimes see that too with sometimes what we call like burnt out fatty liver disease or burnt out MASLD, where once you kind of get that level of cirrhosis in, the liver can't hold on to that fat very well, and you're getting a measurement more because there's more fibrosis in the liver. So that's really what you're seeing. There's not as much fat in the liver anymore because it's getting replaced by fibrosis. And again, this ELF test is consistent with cirrhosis. So that being said, is there any other diagnostic testing for fibrosis that you would want to do on this patient, or do you feel like that this pretty much seals the deal for you? You know what? I'm not even going to make you say it. This seals the deal. Okay. And I would always tell, patients when I'm new people that I'm training for, learning how to do this, is that if you get even a whiff of cirrhosis, call it cirrhosis until otherwise identified or until otherwise it's proven itself, because the risk of missing a cirrhosis, means that you're not enrolling patient in surveillance programs, that you could be missing monitoring for other decompensations. So again, I think that we covered this. No further testing. I think at this point, the cat is out the bag. Would anybody, now I'm just curious, would anybody consider at this point potentially doing a biopsy because of that ANA of 1 to 80, looking for another disease?
I would not. I'm really not impressed by the positive ANA. I was gonna say on the previous case, if we didn't have that ELF score that correlated with that ALT being above 80, you could make the case that, okay, maybe FibroScan overstaged and you'd want a biopsy to kind of prove it that they really had advanced fibrosis. But I think in this case, we have all these concordant results. I don't think you need a biopsy, and I'm not worried about autoimmune hepatitis in this patient. If you had a positive ASMA, then I think I'd be a little bit more interested in a liver biopsy.
Totally. I think I love that answer. That's such a wonderful, well thought out approach to this. And, one of these things, there's a reason why medicine's an art, is because, we're all thinking about this. You might want to keep it in the back of your head. Now, let's say you've got that that ANA of 180, and then maybe, I don't know, I'm just thinking about this. Let's say you do a colonoscopy and you see ulcers everywhere. Okay, maybe then that's a reason that we would want to consider doing something else, or maybe looking at that a little bit more carefully, because one test doesn't really mean a whole lot. ANAs can go up for all sorts of reasons. So they're not diagnostic in and of themselves. Generally, and just also for everybody that might be joining, is that it's a titer. So I do want to just explain this really quickly, is that what they do is they do serial dilutions on the blood to see at what point the antibodies stop reacting. And depending on how concentrated the antibodies are in the blood, you will see further dilutions turning positive. So on a 180, I believe that is only 2 dilutions out, because I think the first dilution is 1 to 40, which is considered normal. A 1 to 80 is 1 dilution out, which is not considered abnormal. It's basically within normal. 1 to 160 is when you start getting 1 to 160 is when you start getting question marks of that possibly being more positive. And again, as it goes further out. So again, it's a multiple of 40 each time that you do it for the ANA. All right. So how would you treat this patient, and how would you monitor this patient? Again, so because we've basically determined that this gentleman has likely cirrhosis, he is not a candidate for resmetirom. We might definitely want to monitor for hepatocellular carcinoma, and we would also want to screen for esophageal varices, and we would also seriously want to consider him or consider counseling him on diet and lifestyle, which I want to make an extra plug for, because the thing about cirrhosis, and one of the biggest impacts of how well you do with cirrhosis is how well can you preserve your lean mass? How well can you make sure that you're eating well and taking care of the rest of your organs? Because the problem with cirrhosis is that it's a chronic organ failure. So or it can lead to chronic organ failure. And we worry about getting too frail for transplant, or getting a significant morbidity just because your body's given out. So at this point, I would strongly encourage him to pick up a weight program. I would recommend trying to lose weight, but with a very high protein diet to help preserve any lean mass that he has. We would also, again, as I said before, want to screen him for decompensations or budding decompensations, especially with that FibroScan showing greater than 20. Now, again, his platelet count wasn't below 100. That wasn't diagnostic, but we would want to screen for esophageal varices. All right, so just kind of comparing these two cases is that we've got, a Fib4 of 3.1, which is in that indeterminate range, an L score that's consistent with an F3, transient elastography that's also consistent with an F3. We've got the Fib4 of 3. I'm sorry, on the second case, we've got a Fib4 of 3.36, an L score of 11.4. Both of these measures are consistent with cirrhosis, and a transient elastography score of 21 kilopascals. So comparing and management, again, when we've crossed that bridge into cirrhosis, our management has to change. At that point, we're not trying to prevent disease anymore. We're trying to preserve what we have. When we're at F3, we can actually drive that back. So we're going to try to drive that back, and we can do that with medications. We can do that. With changing in some of our dietary habits. So again, it's one of those things to just keep in mind when you're assessing how much damage somebody has in the liver. I do want to I know that I'm kind of getting close to time being up, but I think that it's not unreasonable to talk about what happens when you get a whole bunch of indeterminate tests. Like, let's say you've got your Fib4 is indeterminate, or maybe, because again, it's not very accurate for those who are very old or very young. Let's say you've got a 65 or 70-year-old, so you can't really do a Fib4. Your Fib4 on that's going to show abnormally high. And let's say you get an ELF score that's showing an F0 and their FibroScan showing an F4. What do you do? Well, I'll tell you what I would do. I think that that would be the case for when you have something that's wildly different like that and you can't get that. Honestly, I would probably just go ahead and go for the biopsy. You know, you can only go but so far with these non-invasive testing. It's going to catch probably 90% of the people that walk into your office, but it's not unreasonable to get a poke if you're not sure. Like I said, it's not that when we talk about these non-invasive testing, it's not because you should never do it. It's because we can probably get away without ever doing it for most people. But it still has its place. Again, that let's say that ANA was, you know, 1 to 360. Yeah, I would probably poke the liver and see how much of this is autoimmune and how much of this is fat, and see what the driving etiology is here. HCC surveillance, that's hepatocellular carcinoma, is so important. I'm going to make a minor plug right now for a malpractice blog that I subscribe to, called Mal Reviewer, that literally just 2 nights ago posted a case study where somebody treated their hepatitis C and had cirrhosis, but did not start with the hepatocellular carcinoma screening. And long story short, the patient developed a cancer and succumbed from that. And the family sued the provider, saying that you didn't do the liver cancer screening like you should have. And there's a really fantastic discussion. I think it's a beautiful case study of why it's so important. When you have somebody at risk for hepatocellular carcinoma, you need to screen for it. I was trying to think if there was any other disease state where the diagnosis for the disease state and the screening for cancer were 2 different tests. Or you know, I was trying to figure out if there was anything like that, and I couldn't think of anything. So if you guys can think of anything where it's different like that, because that's the difference, is that we have to take a picture of the liver. That's the only way to find out for liver cancer. And again, it's one of these things that if you're at risk, you need to start taking pictures of the liver to see if it's going to be there. You know, everything else that we do, it's either age-based, sex-based, you know, when we're looking for other cancers, or the diagnostic test or the screening test is also the diagnostic test. So, you know, it's just one of these things that is a little bit different of a mindset. And I think it's pretty unique of one of the disease states that we have to work with on that. So I believe that's it. And I'm happy to take any questions or comments or anything else.